Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, and comments that you wish to share with the audience can be typed into the chat box, visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweet or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community, our province, and the country. Today, we're delighted to partner with Solutions for Kids in Pain, or SKIP, to bring you Comfort in Pediatric Critical Care, a challenging new priority in the management of pediatric critical illness. I'd like to introduce our speakers now. Mary Claire Shanahan is a parent to an amazing kid with complex medical needs and a chronic pain patient herself. She has spent countless hours bedside in the Pediatric Intensive Care Unit and acute care settings as the primary caregiver. She's also a researcher studying public engagement with science and research consent processes. These two parts of her life have helped her understand the importance of shared goals and understanding between families and medical professionals. And she's seen firsthand how understanding each other's values, intentions, and goals is essential to creating sustainable relationships for pain management in children. Lori Lee is a Pediatric Intensive Care Unit nurse, practitioner, and clinical scientist at Alberta Children's Hospital in Calgary, and lead of the Pediatric Intensive Care Unit's Pain, Agitation, and Delirium program. Lori is passionate about ensuring that all critically ill children are as comfortable as possible while receiving life-saving therapy. Stephanie Hall is a registered nurse with 7 years' experience in the Pediatric Intensive Care Unit at Alberta Children's Hospital. Stephanie has been part of the Pain, Agitation, and Delirium Committee since its inception, and she's passionate about the prevention of delirium and has future goals for further unit-wide initiatives focusing on continuing improvement of sleep in the Pediatric Intensive Care Unit. Just a reminder that we record all our webinars. As mentioned in the introductory video, please type your questions into the question box at any time, and I'll prompt you via the chat as well. I'll pose your questions to the panel following the presentations. It's now my pleasure to pass the mic to Mary Claire.
Thanks, everyone. It's a real pleasure to be here today and talk a little bit about our experiences in the PICU. And so I'll start here, Laura, if you can go to the next slide. And let's see if I can, there we go. Okay. So I wanted to start out by telling you a little bit about the context, and I wanted to introduce you to my daughter, Evelyn. I'll make the note that this introduction was approved by her and was written in collaboration with her. So Evelyn is 7. She is a determined, hardworking, funny, opinionated, and very creative. This painting represents her pretty well. This was done in the hospital recently, just a couple weeks ago, with materials from the art therapists, but not at all following the directions for the activity that they had planned. She worked on it for an hour, with 3 different shades of red to get it exactly how she wanted, even though she kept getting suggestions about wouldn't she like to add more colors? And the answer was obviously no. And it's because, as she says, she's the artist and no one can tell her what her art can be. And just like her personality, her medical history is kind of nonconformist as well. She doesn't fit in anyone's neat diagnostic boxes, and never has. One of the comments we had when she was really little was, one of her cardiologists was introducing her to some medical students who were going to come and listen to her murmur because it was really loud. It was an easy first murmur for people to hear. And they started asking sort of the typical questions you would ask if you've read the textbook on pediatric cardiology. And he just stopped and said, no, don't bother with those questions. Evelyn doesn't read any of our textbooks. So none of the things that they were going to talk about were going to be as expected. She has multiple rare diseases, and it has included liver disease, congenital heart disease, bowel disease. She's had 10 major surgeries, countless small ones, spent time in 5 children's hospitals in Canada and 1 in the US, and has been admitted to the PICU in all but 2 of those. And almost all of those situations have involved painful medical mysteries of some kind or another, where treatment plans were unclear, sources of pain were unclear, and everyone was working together to try to understand what was going on. So both Evelyn and I really do know a little something from the patient and family end about pain and comfort and trauma in PICUs. And that's really what I wanted to share a little bit about today. Laura, you can go to the next slide. Just like Evelyn has been a medical mystery for everyone who's encountered her, along the way over the past 7 years, her first surgery was her first major heart surgery was when she was 6 weeks old. So this has really been her whole life. And along the way, I have been that parent many times. I've been the first timer who was scared and overwhelmed and just looking for someone to tell me that everything was going to be okay and that they were doing everything they could. I've been the exasperated frequent flyer, just trying to tell everyone who would listen to just do the thing they did last time because it seemed to help. And I've been the stoic bedside assistant, knowing that really hard things had to be done and being there and willing to help, holding down for procedures and doing really challenging things for both Evelyn and myself. And I would say only recently, what I would, I guess, call a fierce advocate, when ongoing and unexplained pain really became an untenable issue for her and a really a bigger part of what we were trying to solve in the ICU. The first 3, I will say, just came naturally. They were just reactions to the situation. I was scared the first time we were there, and I couldn't think of any other way to be. I have certainly been that person just trying to get somebody to do the thing they did. And I felt along the way that I didn't want to be that parent who was too scared to help, and that I would rather be in the room with her when difficult things were happening to be any source of comfort, than to choose to not be there. But it was really the 4th that was something that I actually had to learn and change what I thought about pain and what I thought about her experiences and what I really thought about what was important when we were in the PICU. Because as I said, I had certainly and have certainly over the years helped with things that I knew were important, medically important, and said yes to ways of doing things because I was told this was really important. It had to be done right away. We have no other choice. And as I said, sometimes that has meant, helping to restrain her, holding her down, and doing things that I never thought I would do, but I felt at the moment were important. And changing that thought that the first priority should be just always listening to and thinking in my mind that prioritizing the what needs to be done and how quickly, that's always the first and most important thing. That was something I really had to work very, very hard to change, and has brought us both, I think, to a much better place over the past few years. So in terms of that, as I said, we've had tons of experiences, and it was only a few years ago, probably about I'm going to guess about 3 years ago, although the last year for everyone's been a blur, so it's hard to say what was a year ago. But about 3 years ago, Laura, you can go to the next slide. We really first had our first exposures to people saying, hey, we should try to think more about her pain experience, and we started seeing kind of posters around the hospital and people coming to talk to us about things like comfort care. We were introduced to things like comfort positions for injections and for IV starts, the little buzzy bee thing, and other similar little gadgets that you can that can address reducing pain in different ways. Freezing cream, which now there's, again, in our emerge department everywhere, there's a lot of signage about trying to use freezing cream and things before injections, using distraction. That we were already using. She's a very competent YouTube user, has been since she was about 2. So that wasn't one anyone needed to teach us about. Warm blankets, deep breathing. And when we were first introduced to that, I thought, okay, great. Yeah, I'd love to try to help her be more comfortable. I would love to try and make these things easier. Sometimes she has to endure, 13 tries at an IV start. Sure would be great if we could, with something simple, like just sitting a different way, make that easier. Laura, you can go to the next slide, which is very similar. And what our experience is that all of these things just made things worse. They disrupted the routines we already had. They made her more anxious because, again, the comfort positions were either unfamiliar or different, or they felt like they were being explained with a degree of anxiety that, this will help. The freezing cream created just now a timed anxiety about injections. So instead of just having the pain and the trauma of the injection, there was 30 minutes of anticipating it beforehand and then having to peel a really painful dressing off, which really, in some instances, just hurt more than the injection had. Distraction always worked. I won't say anything bad about YouTube. Warm blankets that she would kick off, and we realized felt like restraint, felt like sort of the way that you would bundle an infant, but that for kids who are in the hospital, a lot gets used much, much, much later in their lives, and really feels very, very distressing. Someone even offered to do it to her recently. I'm like, no, she's 7. We're not. No, absolutely not. And again, deep breathing, like the comfort positions, just felt like another command, another thing that she had to do, and another thing that was just really making things worse. The first few experiences we had with this led to absolutely massive meltdowns, both on her part and honestly on mine, because I felt really helpless. These were the only kind of solutions that we were being offered. And I knew that I seemed cruel for turning them down. But I knew that the last time we had tried it, it had done nothing good. And we were at least better to just go back to what we had been doing, which was at least had the comfort of familiarity. But as I tried to figure out what else we could do, I also felt really blamed for refusing to hold her down and restrain her. Didn't I understand that these things were essential and that she had to do this right away? And didn't I understand? And why was I taking it so much to heart? And I really tried desperately to find ways to get things done without causing any more pain, which meant things taking a long time. But mostly, honestly, I actually just felt really, really, really alone. Like there must be something wrong with us. We're not doing this right. The people who are offering these solutions are saying that they should help. I looked at the literature. I'm a researcher. It's what I always do. And they seem to say that these things should help. So therefore, there must be something wrong with us. We're doing this wrong. We've done things wrong. And I had a really hard time finding any way to try to solve that problem. But as I did notice, as I was going through it, most of the things that we were being offered and talked to about were really kind of inappropriate for the situation. They were for kids who hadn't spent a lot of time in hospital, kids who didn't have significant trauma, kids who even necessarily didn't have significant communication issues with expressing their fear and pain, and for situations that were on a completely different scale level of pain, and an immunization versus versus a PICC line inserted without anesthesia at bedside, and that as I started to think about it, there was no way that these things were going to be the things that were going to help in the situations that we were in, but it really left me at a loss because I couldn't find any resources for what to do about the kind of pain that we were encountering. Laura, you can go to the next slide. So what finally did help, because I did say that we did finally get help. The most important thing when dealing with our experience of pain and comfort and delirium, as an extension of all of that, was first being exposed to the possibility of trauma care, and really understanding that the reactions that both I had and my daughter had were manifestations of trauma, and that had to be dealt with before any other of the kind of more typical interventions would work. And that very often our reactions, again, mine and hers, reactions to suggestions about sleeping more, about being more awake, about the kinds of things that I think Lori is going to talk about, our reactions to those were very, very much the panic and fear of trauma. And those things couldn't help us because we couldn't receive them in the way that they needed to be. And so we spent a lot of time creating a sense of agency and autonomy for Evelyn, really working hard with bedside nurses on very subtle things about caring without judgment or scolding, that when she refused something or lashed out or tried to hit people, that the answer was not scolding and the answer was not restraint. And that really, these things would only make things worse. And approaching her and her reactions to pain with patience and kindness at all times. And we were actually really helped, Lori might be able to guess who I'm talking about, but we were really actually helped by a PICU nurse who had spent a considerable amount of time in the hospital as a child herself, and made a sign for beside Evelyn's bed in beautiful, colorful writing, just saying, I respond best to kindness, to remind everyone who came into her room that commenting on her not being nice or not saying please and thank you or being angry and scolding and trying to teach her a lesson was just absolutely not going to have the desired results. That these were the things we actually had to do first. And that no amount of comfort programs or checklists or pain scales even could help if we didn't do these things first. And in addition to that, in terms of creating that sense of agency and autonomy for her, was always taking her pain seriously, and not downplaying it, not falling into the parental pattern of, if I just ignore it, then it won't be, they won't see it as pain because they just want attention or whatever it is. Lessons we sometimes learned a long time ago from our parents that maybe aren't the greatest. But that always take her seriously. I hear you. You're right. Okay. If you say that hurts, it hurts. And we will find a way to help with that. And so for Evelyn, we've now gotten to a place where we do use multiple pain strategies, multiple comfort strategies, where we have lots of non-pharmacological options for dealing with pain. But we couldn't start there. We actually had to show her we took her pain seriously by treating it as pain and involving the acute pain service, all the time for her, involving the complex pain service, but actually taking these things seriously and not being held up by, oh, don't worry, it doesn't hurt that much, or I don't see a reason why that should hurt, so I don't think it does hurt, because we've also learned that she really does have, her body is physiologically different when it comes to pain receptors in places where she's had multiple surgeries. And so what I imagine would hurt is not the same thing that would actually hurt for her, but always taking it seriously and always treating it as pain first. And very often with pain medications, with things that turned into more sedation rather than less, we got to a place where we can use less sedation, where we can use non-pharmacological options. And that we were really lucky to have people who took that seriously and allowed us to have that journey to get to where we are today. So Laura, you can go to my last slide now. So the things that I really wanted to come here and say is that pain in the PICU really can't be about the same strategies and knowledge drawn from more everyday experiences. I would, given the number of family and friends that we have that have both experienced the PICU as complex care patients and frequent flyers, as well as friends who have had one-time admissions for asthma attacks or accidents or sort of other more one-time admission kind of things. For everyone, trauma is involved in some way, for every patient and every family that's there, whether it's new and immediate trauma and shock, or historical trauma that has built up over years. And that need for us, I would want people to know that has to be front and center before pain and comfort care can really be effective and even maybe received in the way that it's intended. And those things have to work together. That is the things I wanted to come and say, but I also wanted to add to that is that when we had the chance to do that, we got to the place that I think the kinds of things that Laura's going to be talking about, again, less sedation, less pain medication, non-pharmacological options, creating a comfortable, safe space. But we had to work through the trauma of our previous experiences to be able to get there. And so always being aware that it's not as simple as, hey, we're just going to change our policies on this. There has to be a way to get families and patients into a place that they're ready for those things. Okay, thank you very much, everyone.
Thanks so much, Marie. Such a powerful talk. And I think, and I've experienced some of Evelyn's journey. Obviously, she's been in the ICU a fair bit. And I feel like, certainly in my last couple of experiences with her, that I think we unknowingly failed her initially in her ICU admissions because we didn't understand how important all of this was, from pain management right through to the trauma piece. And what I hope that Stephanie and I are going to talk about is a change to our approach to pain from day one, so that we can actually prevent some of that initial trauma from happening. I've been in PICU either as a registered nurse or as a nurse practitioner for 20 years now, and have done things in the best interest of my patients that now that I have the knowledge and understanding, in hindsight, know was not in their best interest. And that's what Stephanie and I are going to talk about, is how do we need to change our approach and our thinking around pain in the PICU to hopefully prevent some of the trauma that children like Evelyn have suffered right from the get-go, and then how to improve their pain experience as they travel through the ICU. So we're going to focus on three main topics here. What do we know about PICU-related pain? How do we assess it? Because that's important. And then how can we treat it in a comprehensive, holistic way? So children that are in the PICU experience a lot of pain. Over 85% of children, and in some studies up to 100% of patients, will experience pain during their PICU stay. And almost half of those kids will experience it every day of their ICU admission. Children in the PICU have significantly more moderate to severe pain than those admitted to the general medical surgical units. Their pain scores are 2.2 to 3.5 out of a scale of 10, higher than children in the general inpatient units. And yet, despite that, pain management in the ICU up until, as Marie mentioned, sort of 3 years ago, was not a focus. The focus was on keeping children sedated, which is not the same as pain management, and in delivering life-saving therapy. We're in a good position in the vast majority of children survive their PICU stay, which really puts a responsibility on us now to make sure that we are doing better than survival and that we are not causing any more trauma than children already have from being admitted to the ICU. So we know that pain is common. We also know that pain is not well managed in the ICU. And there's been 3 big studies in the last 10 years, all a little bit of time ago, actually, 2010 and 2015 and 2012, looking at pain as an adverse event in the ICU. And what I think is really fascinating about these studies is they are the second most common adverse event in ICUs in several of these studies. The only more common adverse event is interstitial IVs. And one of the reasons that we'll get to that healthcare providers are often reluctant to use adequate pharmacological pain management strategies is out of a concern over other adverse events. And you can see in the graph on the left, inadequate pain management occurred of a study looking at all adverse events. Inadequate pain management was almost 10% of the adverse events, whereas other adverse events such as hypotension, constipation, withdrawal, oversedation, and respiratory depression, which are all things we worry that pain medications will cause, occurred much less frequently. And when you look at the half pie chart there, inadequate pain management far exceeded the rates of withdrawal. However, we reduce the exposure to analgesic medications in our patients in an effort to prevent these other complications. And what we're doing, unfortunately, is increasing the complication of inadequate pain management. And as we move on, I'll talk more about the program that we've implemented at the Alberta Children's Hospital to improve this over the last 5 years. But one of the more recent initiatives we've done is as part of our morbidity review and our quality assurance review in the ICU, inadequate pain management is now an adverse event that gets reviewed monthly in the ICU as important as a central line infection or a ventilator-associated pneumonia or accidental extubation. And what's interesting is all of those other adverse events happen much less frequently than inadequate pain management, and yet up until very recently has not received the same amount of focus. Marie-Claire talked a bit about the painful procedures that Evelyn went through. She is not alone in that. The average number of painful procedures any child admitted to the ICU experiences is anywhere from 6 to 12, depending on the study, and the range is anywhere from 0 to 70 per day. Children's pain in the ICU is a combination of their underlying disease process. So did they have surgery? Do they have some ischemic bowel, abdominal hypertension, peritonitis, chest pain, trauma? So they come in with baseline pain-causing injuries or illnesses. And then we do a significant number of painful interventions to our children every day. What's really interesting is in studies of both children and adults in ICU, they report some of the most painful procedures being things such as turning, suctioning of the ET tube, chest x-rays, wound care, things that healthcare providers do not estimate as being painful. So to highlight what Marie-Claire said, what we think is painful and what our patients think are painful are not the same, and they are the experts in their pain. And going back to the last slide, we overestimate the risks of treating their pain and underestimate the impact of missing their pain. And this, if there's one take-home message from this entire talk that I hope people have, is that patients are the expert in their pain, and we need to treat what they define as pain. Another really important point to understand about procedures in PICU and across pediatric inpatient care is the importance of IV cannula and needle poke procedures. So children estimate in several studies that IV cannula insertions are the worst or second worst painful thing done to them in hospital, second only to major surgery that they had in hospital. And especially in the ICU, we really underestimate the distress and pain caused by these procedures. And we often justify improperly analgesed needle poke procedures in urgency, rush, and the need to save a life. And though that occurs in a few situations, the vast majority of the time that we're putting in IV cannulas and doing needle poke procedures in the ICU, we actually do have time to do them properly with appropriate analgesia. We just have to change our way of thinking about the urgency of these therapies. And I think it goes back to historical underestimation of children's ability to experience pain, as well as the importance of that pain experience for them, both in their ICU experience, but also long-term. The European Society for Pediatric and Neonatal Intensive Care actually came out with a consensus statement a few years ago about pain, sedation, withdrawal, and delirium assessment in critically ill children. And this was a real trigger point in changing the way we care for our children. Before that, routine pain assessment was not part of the standard of care in PICUs, and certainly in ours, less than 20% of children even had one pain assessment done in a day. So the grade A recommendation from this position statement was that children needed an age-appropriate tool to assess pain, both acute and prolonged. They recommended some European-based tools. There were other recommendations that weren't able to be as well evidence-based, but they were that pain assessment audits should take place regularly. Pain assessment should occur on a regular basis. And we should be identifying potential sources of pain and taking appropriate actions. And that parent and family assessment of pain should also be considered in pain assessment for children that can't communicate as well. And so this position statement really changed certainly the way our unit looked at pain in critical care, and really set the stage for us implementing our pain, agitation, and delirium program. Now, we wanted to implement really valid, accurate pain assessments, but unfortunately, there's significant challenges to our ability to assess pain in pediatric ICU. And Steph is going to talk as the expert and someone who does these every 4 hours in every shift plus more, talk about many of those challenges.
Just let you go to the next slide, Lori. So yeah, as Lori said, before we can become successful, we have to first understand those challenges that do exist in pain assessment in the PICU. So though there's clear recommendations on the need for regular pain assessment in children, there's many challenges to this. And these challenges can be related to communication abilities, confounding of other symptoms or syndromes, and as well as the confounding of just the ICU therapies that we provide. So due to changes in acuity and treatments like sedation, paralysis, ventilation, children's ability to communicate their pain can change throughout their stay in the PICU. Different children also have different abilities to communicate their pain due to their developmental age, stage, whether they have typical or atypical neurodevelopment, and depending on their culture or ethnicity, as these can affect how they display and communicate their pain. Self-report is the most valid and reliable measurement of pain. However, this is often very difficult for our critically ill children. Louise et al. Found that only around 20% of patients actually used self-report to have their pain reassessed. There's many tools to aid in self-report and observed pain behaviors, and many of these have been validated in neurotypical and developmentally delayed children. And then their ability to express the presence of pain only emerges about at the age of 2. But developmentally appropriate children as young as 3 years of age may be able to quantify their pain using some of the simple validated pain tools that we have. So this study was actually really great at the pain assessment practices in the pediatric ICU. And so that stat there that I found was very, very mind-blowing and validating for me as a bedside nurse even, was that only 7% of our children do not have a barrier to communication. So Lorez and their group, they surveyed nurses about children in the PICU and their ability to communicate their pain. And they found that only 54% were able to communicate in some way. And of that, only 34% were able to communicate their pain effectively with the healthcare team. Some of the barriers to communication were 37% were found to be pre-verbal, so too young. 30% had a cognitive impairment. Another 30% had sedation impairing their communication. 11% were too ill to communicate. 6% only spoke to their family. and 2% did not speak English. So really, when we have that stat that only 7% don't have a barrier to communication, it really shows part of the massive challenge that we do face. So in the PICU, our patient population is obviously critically ill. For sure, the culture for some time has been when a patient is deeply sedated or on a neuromuscular blockade, we would look towards vital sign changes as an indicator for their pain. However, studies using vital signs as an indicator for the presence of pain in neonates, infants, children, and adults have all found inconsistent findings. Hare et al., they found that physiological indicators such as the changes in their heart rate, blood pressure, and respiratory rate, though important for assessing potential side effects, are not sensitive for discriminating pain from other sources of distress. They found that there's too many confounding factors in critically ill children, such as their underlying disease process, medications, and mechanical ventilation. Arbour and Jelinas found that the correlation of vital sign changes with behaviors and self-reports of pain has been weak or absent. So overall, while vital signs are easily accessible to the whole healthcare team, they should only be a part of the comprehensive pain assessment that we perform. This chart shows really how hard it can be to differentiate pain from the other syndromes, such as withdrawal, delirium, and under sedation. When you look in the middle of that chart, it lists vital signs such as heart rate, resp rate, level of consciousness is in there. And it's easy to assume in certain situations that your patient's agitated due to delirium or that they're under sedated. And at times we would go to that first as our treatment, when in fact, all of those signs can be directly related to pain. Young children have a difficult time discriminating between the sensory experience of pain and the distress or fear of pain, as well as distressing symptoms such as nausea. Something that we've talked about and that's been found is an analgesic trial can be helpful in distinguishing distress behaviors from pain behaviors. Because it's confusing, and you just look at that chart, it is confusing, utilizing a pain-first approach will ensure that we always work towards achieving adequate analgesia first. Because of the complexity of pain assessment in children, bedside nurses, such as myself, are called upon to use our critical thinking skills to interpret the child's clinical state. This can often end up being a barrier to adequate pain assessment and management. Despite evidence for the use of validated pain scoring tools, bedside nurses continue to use multiple variables to assess pain and determine pain management. So Lafond in 2015 performed a study where they played 40 PICU nurses, 4 vignettes of children in pain. And so in all the 4 vignettes, the children were male, they were African American, and they were the age of 10. In 2 of the vignettes, the child was admitted with a sickle cell crisis, and in 2, they were post-op day 1 from abdominal surgery. For each of these diagnoses, one of the boys was smiling and one was grimacing. All 4 of the children, when asked, rated their pain as 8 out of 10. So despite evidence that self-report is the most accurate pain assessment tool, bedside nurses report using many other factors to determine their assessment and treatment decisions. This includes behaviors as well as vital signs. So it was found in the study that 55 to 90% of pediatric nurses believe that children sometimes over-report their pain levels. It's easy to say, well, they said they were 8 out of 10, but they were smiling or their vital signs had not changed. And for sure, that's something I know that I've said myself many times. And when we walk into a room, we may meet our patient or family for the first time. So we sometimes don't know their history and their trauma in that. And it's easy to realize that we depend on those cues more than we realize. We all inherently have our own biases, and this study really shows how easily they can skew how we treat our patient's pain. This study looked at the ethics behind unresolved pain in children. And while the focus of the study was for the nursing assessment of pain, and I didn't love all parts of it, but the part that I really did like was talking about the myths and misconceptions, and that's in the outer ring in that figure there that exist around pain. And so some of the statements are, there's a correct amount of pain for a given injury. Children become more accustomed to pain, that infants do not feel pain as their nervous systems are immature. An active child cannot be in pain, or a quiet and sleeping child must not be in pain, that pain is not life-threatening, that children do not have a memory of pain, and that narcotics are dangerous for children with an increased risk of addiction. Sadly, in my career, and I'm sure all of ours, we've heard all of these phrases used in order to justify how we're managing or mismanaging a patient's pain. So as mentioned, we've talked about the nursing assessment and the barriers that nursing faces for pain management, but we can look at it from a broader healthcare provider scope. So Bhatia in 2014 explored the pain management barriers that existed in critical care units, including PICUs, and the study was specifically done in Jordan. He identified many barriers at the level of healthcare providers, such as inadequate knowledge about patient sedation, inconsistent practices around administering pain medications as needed, so truly what PRN means, the limitations and the heavy workload that exists in the PICU, the inadequate communication between healthcare providers, the fear of side effects of pain medication, physicians' lack of trust in the nursing assessment of pain in critically ill patients, and finally, the lack or inadequate staff knowledge of pain management as a whole. So therefore, without supportive interprofessional collaboration and through education, PICU nurses and the whole healthcare provider team may be further challenged to provide optimal pain management in children. And I'll pass it off to Lori.
Thanks, Steph. So as you can see, we still have a long way to go, but we know now that there are significant consequences to unmanaged pain, and Marie certainly spoke very eloquently about that. What we know from the literature that are the consequences to unmanaged pain in children is delayed wound healing. We know that children have an increased response to pain in adulthood if they had inadequately managed pain in childhood. There's an increased stress hormone release, which can have impacts on immune function in critically ill children. Children who've had inadequate pain management have avoidance of medical care in adulthood, and significant post-traumatic stress in children and their families with anxiety and trauma symptoms into adulthood. So as we begin to understand how important pain management is, and to recognize the many barriers to adequate pain assessment and pain management in general, but specifically in ICU. At the Alberta Children's Hospital, we've worked really hard as part of a larger program looking at pain, agitation, and delirium to take a pain-first approach. So about 5 years ago, we implemented the PICU pain and agitation pathway. And one of the first things we actually did was change the title of it. It had been called the Sedation and Analgesia pathway, and it really reflects a approach to comfort in the ICU. Historically, was really around sedating patients to ensure they accepted our therapies, with very little focus on analgesia. And so our first step was really to flip that around and make this a pain-first, analgesia-focused pathway. And it starts with really baseline management. So we target a pain score less than 3 in every patient. We order a daily sedation goal, and then we assess for pain every 4 hours and as needed, as well as assessing for agitation, delirium, and withdrawal. We start by maximizing our non-pharmacological interventions, which is clustered care, quiet environment, day-night cycle, etc. But any pain is treated with a PRN prior to all potentially uncomfortable procedures. So this is step 1, which is expect pain and treat it. We know that ICU procedures are painful for our patients, turning, suctioning, repositioning. And so we should be managing that with an analgesic before any of those procedures and not waiting till we cause pain to treat it. Once we're doing all of those things, then we do our regular pain assessment. If our pain score is elevated, we don't move on to assessing for agitation, delirium, or withdrawal. And that's part of a pain-first approach, meaning that assume it's pain before you reclassify it as one of those other syndromes. We rule out reversible causes and maximize non-pharmacological intervention, and then rapidly reassess the pain. If it is still elevated, then all children should get a PRN analgesic as is ordered in their order set. This cycle of treat and reassess is managed by our bedside nurses with a PRN medication and then a range of baseline infusion for their pain medications. And then only once we have given greater than 2 PRNs in 2 hours do we increase our baseline analgesic infusion. And only once we've achieved good pain control do we move on to our agitation assessment. As Steph talked about, we still have a lot of the same barriers that those studies uncovered in terms of our interpretation of the pain. And I echo what Steph said as well about that one study really identifies some important myths that we experience. But as an advanced practice provider and working closely with the medical team, those myths are absolutely not restricted to bedside nurses, but those assumptions exist in all members of the healthcare team. And still on a fairly regular basis in our ICU, and I would assume any across the world, do we come across, well, but he slept well. He said his pain was 7, but he slept all night, so it can't be that bad. Or she said her pain was 6, but then she was building Lego, so it can't be that bad. And I think one of the biggest challenges moving forward in pain assessment in critical care is going to be taking away our preconceived notions of what we think the pain should be and really focusing individually on each child for how much pain they're having. Now, despite the fact that I think we still have a lot of work to do, we have really made some significant headway in this process. You can see these status process control charts showing the 3 phases of the implementation of our PAD program through 2016 to 2018. And I can tell you that these results have maintained. We were able to reduce our rate of significant pain, which is pain scores greater than 4, from about 20% of all our pain scores down to about 12% of all of our pain scores. And we did that without a huge increase in the number of days or amount of medications that were given. And the reason I think that isn't necessarily because we only focused on non-pharmacological therapy, but I think in early recognition of pain and adequate treatment of pain for most of our patients meant that patients didn't get into a pain crisis, and therefore we were able to have better management of their pain without necessarily giving a lot more medications. We still have a lot of work to do, but we're headed in the right direction. I think what's important, and I hope that this addresses some of the issues that Marie brought up as well, is pain needs to be approached from a holistic perspective. And this is the 3 Ps of pain management are well established by pain care teams and acute pain services, but really need to be brought into the ICU so that we can provide this holistic approach to our patients. And what the 3 Ps are is looking at physical, pharmacological, and psychological approaches to every kind of pain. The physical approach is a really important one that we are embracing in the ICU, but still have a lot of work to do, which is do the least painful procedure possible. Now, what that means is don't put in the IV just in case they might need it. Don't do a needle poke for blood work that isn't going to change your practice. If you're going to put a chest tube in, make sure you need it and make sure you do it in the least painful way using the smallest, least painful tube that you can. Historically, in critical care, with a focus on life-saving therapy, we have done a lot of unnecessary painful procedures to our patients. And so the first step in improving pain management in children in the ICU is making sure we're only doing those procedures that are absolutely necessary. The second step is the pharmacological approach, and this means using all modalities from topical numbing cream, regional to systemic pain medications. And then the third is the psychological approaches, which is the positioning, distracted, guided imagery, and memory reframing, etc. I also want to further echo something Marie-Claire said in her talk, which is that the psychological approaches don't work in a traumatized patient. And so if we implement this 3 Ps approach to all painful procedures and pain management from the day a child walks into our hospital, then we actually have the potential to decrease their trauma exposure and hopefully mitigate some of that trauma response from the get-go. For the children that received care before this became a priority that already have trauma, they're going to require more pharmacological approaches before we can implement those psychological approaches because of the trauma that they have already suffered. And this process and these 3 approaches to pain management need to be tailored to every patient's individual needs. And we need to take the time and have the patients to do that except in true life-threatening procedures, which I believe are much more rare than those of us in ICU describe them as. I wouldn't do a pain ICU talk properly if I didn't briefly talk about analgesia and sedation medications. This is a beautiful study from last year looking at all of the different medications that children are exposed to. With a focus on analgesics, this study of 66,000 children in ICUs in the States found that only 58% of those patients received an analgesic during their ICU stay. Those that were intubated all received an analgesic, but those that were admitted for other reasons didn't. And that includes both non-opioid and opioid analgesics. So important to know that we probably still aren't doing a good enough job of analgesing all of our patients that come through the ICU. A consistent approach to analgesia is important. There is not good evidence for one opioid over another, but this is an example of our table of preferred medications so that all of our patients come in with the same basic approach, and then we deviate from this as needed for patients that have specific pain needs. There's emerging evidence about the benefits of non-pharmacological therapy on children in critical care, and these include the use of music, touch and reading, massage to help improve their comfort and decrease their pain. And a multimodal approach is likely what will be needed to make our patients the most comfortable. Comfort positioning can be helpful again to children that are new to the ICU environment. It needs to be specific to the child and their family, and it needs to be in relation to their own current and previous experiences. We often think it's not possible to use parents for comfort in the ICU, and this is an initiative that we're employing to allow parents to use comfort positioning if it works for them and their child. And again, to highlight something Marie-Claire said that is so important is this should be an intervention that is offered to families, not enforced or pushed on families. Every child and family is different, and certainly should we never in any way be making families feel guilty for not being willing or able to participate in these, because they know their child and their family best. My current passion for trying to improve the overall comfort of children in ICU is really looking at cuddling or comfort holding in critically ill children. This is a standard of care in the neonatal population. It's been shown to improve comfort, decrease pain, improve physiological parameters, parental bonding, and decrease trauma for children and their families admitted to the NICU. However, it is not common in critically ill children. We just finished a scoping review that's just been accepted for publication about comfort holding in the PICU. It's provided inconsistently and really is uncommon outside of infancy and end-of-life care. These tables are just being analyzed for a reanalysis of some data from something called the PICU study, which was a mobilization study, but also captured data around comfort holding. And as you can see, of all of the children in the study sites, which was most PICUs in Canada that had been admitted for more than 72 hours, children less than 2 were often held by their parents if they were in the ICU for 3 days or more. About 82% of those kids received comfort holding on that day. However, children over 2, so 3 to 18-year-olds, were rarely held. Despite evidence showing that school-aged children that are well still significantly benefit from cuddling and being held by their parents. We don't have a lot of time for questions, but I just want to close by saying that this is an area that hasn't received the focus that it should in the care of critically ill children, but we're starting to really come a long way. As we learn more about post-ICU syndrome in children, which is a huge emerging area of research, we will learn more about the consequences of unmanaged pain in the ICU. And so I would ask you to take home the one message that every single one of us can do better on every day that we care for children in the ICU. And one of the biggest barriers to adequate pain management of our patients is our own preconceived ideas about the urgency of procedures and about the child's pain experience within our own context. And so really focusing on our own biases, I think, will do a lot to improve the care we provide to our children. So I don't know if there's any questions.
Thank you all for that great presentation. There are a couple of questions, but this is my chance to prompt once again our audience to type those questions away as you think of them. So is the pathway that you shared and your medication, preferred medication regimens available online or for others?
It will be available online widely. It's not right now. We're just working on the website, but I'm happy to share it with anybody. My email address is up there, so anyone can email me, and I'm happy to share that and the other documents of our program.
Have you ascertained child and or parent experiences of care as a result of some of your pain and agitation reduction strategies?
Yeah, that work is underway. So we are doing some interviews right now, more focused on delirium and children and family experiences around delirium. The pain stuff comes up in those studies for sure. And a lot of the language echoes some of the things Marie said, which is parents feel that the child's pain is not always taken as seriously as it should be, and that there's a discrepancy between what the child describes as their pain, what the parent describes as their pain, and what the healthcare provider team feels is the real pain assessment. Some families really appreciate the use of all of the comfort measures like the numbing cream and the holding, and other families find it very stressful and difficult to implement. And so really targeting that to each patient seems to be an important theme that is emerging. One other thing I didn't have time to talk about today that has come out in some of that research is the challenges of children with significant developmental disability. And that's probably a whole talk unto itself. Those children are exquisitely hard to assess and probably have significantly more pain than we appreciate. And their parents certainly think that that's true.
Thank you. Next question is, besides distraction, what psychosocial or psychological therapies are you using in your PICU?
So definitely distraction is the most prominent one. We had an initial program that unfortunately didn't take off that we need to look at again around nurse-led hypnosis and guided imagery. And then the other one that we're starting to implement a lot more is memory reframing. The guided imagery is difficult because the ICU is a really loud, noisy, stressful place. So it's really hard for patients to buy into it. I've had some really good success using guided imagery, and a few of our nurses are trained in it, as well as the hypnosis. And then the memory reframing, we're really fortunate that we have Melanie Knoll is a psychologist that does a lot of work in pain and memory reframing, who is out of the Alberta Children's Hospital Research Institute. And so that's been a big focus at our site in terms of taking what wasn't an ideal pain experience and helping the child process it afterwards.
Are there child life specialists in your PICU that provide some of that psychosocial support to children and their families?
Yes, and they are instrumental in a lot of this work. We used to have a dedicated child life specialist and then moved to a more site-wide model, and recently have moved back to PICU-specific child life specialists. They're available for us to call in for procedures on children that are able to be distracted or engage in some of that guided imagery. For some families, they are immensely helpful, and for other families, it's an extra person that the child doesn't know. So again, it's really tailoring it around the child. But they provide a lot of the education to our bedside team around how to provide those distraction therapies and help us have all of the cool tools and toys and things to help with distraction. So they're an integral part of our team for sure.
And do they also provide some of that education to family members?
Yeah, they do. I think they do more of it on the inpatient units or in the children that are in the ICU longer, for sure, but they engage with the families as well.
And what might be our last question is, what pain scale do parents fill out for their child who is nonverbal?
So parents don't complete a pain scale. Often what happens is we use the FLAC scale, which is an observational tool, and then the nurses, and Steph can maybe answer this question better than I can, but then the nurses, often how those developmentally delayed kids get assessed is a conversation. Do you think, Johnny is in pain, or is this what he normally looks like, is often how that pain assessment occurs.
Okay. And the last question, what are your next steps?
So for the comfort holding study, we're currently doing a national survey of healthcare providers and families to try to understand the barriers to comfort holding in PICU. And then we're also looking at analyzing all the data from our quality improvement program, some of which I showed you here, to be able to share that broadly about what has worked and hasn't worked in our unit. And ultimately, my goal is to study the benefits of comfort holding and how that can really improve comfort for children and their families. And also as a unit, we're looking at integrating trauma-based care into our unit so that we can address the children we didn't do a great job on pain management historically and help address some of that trauma while they're in the ICU.
Wonderful next steps. Well, that's the end of our time together today. Thanks, Lori, Stephanie, Mary Claire, for sharing your time and expertise with us. And thank you, Skip, for your continued support of our webinar series. Thank you to all the members and attendees who choose to join us. We know how busy you are right now, and we hope you depart with some practical knowledge to bring back to your organization. Join us again on May 26th at 11 a.m. Eastern, when we're pleased to partner with the Pathways in Autism study to bring you the first in a series, Pathways in Autism Spectrum Disorder, a Canadian Lens. We also invite you to save the date for our 2021 annual conference, taking place virtually from November 22nd to 26th. The theme this year is From Crisis to Catalyst, the next chapter for children's healthcare. And the call for abstracts is now open until June 13th. It's always great if you can watch live, as your questions and comments enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Lori, Stephanie, and Mary Claire, and again to Skip for this presentation. And hopefully we'll see many of you back here on May 26th. Bye, everyone.